Hello and welcome. Today, we're going to tackle a word that's used all the time but is often misunderstood: miscarriage. It's a deeply personal experience, for sure, but in the medical world, it has a very specific meaning. We're going to break down exactly what doctors mean when they use this term and why that precision is so important.
So let's just jump right in with a question. If a pregnancy is lost at 7 months, is that medically a miscarriage? Now, instinctively, a lot of us would probably say, yeah, of course. But the clinical answer is actually no. And understanding why that is, well, that's the key to this whole topic.
Okay, so here's our game plan for today. First, we're going to look at the official medical timeline for pregnancy. That's going to lead us straight into the most important concept here: viability. From there, we'll dive into the 5 distinct types of miscarriage, explore the biological reasons they happen, and finally, look at how doctors diagnose and manage them.
All right, first up, the medical timeline. In medicine and especially in obstetrics, precision is everything. Every single week matters. And when we're talking about pregnancy loss, when it happens completely changes what it's called.
So, a typical 40-week pregnancy gets divided into 3 distinct phases when it comes to a loss. Any pregnancy that ends before 24 weeks is, clinically speaking, a miscarriage. Now, the technical medical term for this is spontaneous abortion, which can sound jarring, but all it means is that the pregnancy ended on its own before the fetus was viable. A loss that happens between 24 and 36 weeks, that's called preterm labor. And after 36 weeks, it's term labor. So that loss at 7 months we asked about, medically, that falls into the preterm labor category.
And this all comes down to one absolutely critical word: viability. This concept is the reason for that sharp dividing line at 24 weeks. So, what does it actually mean?
Okay, so here's the difference, and it's a big one. Viability, which happens around 24 weeks, means a baby can survive outside the womb. But, and this is a huge but, only with a ton of medical help. We're talking ventilators, incubators, the whole 9 yards. Maturity, on the other hand, that's around 36 weeks. That's when the baby's organs are fully developed and they can function pretty much on their own.
And this isn't just medical jargon. It has massive real-world consequences. Viability is a legal threshold. A baby born after this point who doesn't survive is issued a death certificate. They have legal rights, like the right to inheritance. This age also isn't set in stone. It changes with technology and actually varies by country.
So now that we've got the timeline straight, let's get more specific. When a loss happens before that 24-week mark, doctors classify it into one of 5 types. This isn't just for record keeping. It's essential for figuring out the right way to provide care. This table is really the key to diagnosis. And it all comes down to 3 things. Is there bleeding? Is the cervix open or closed? And what's the status of the fetus? Let's walk through it. A threatened miscarriage is like a warning sign. There's some bleeding, but the cervix is still closed and the fetus is alive. With an inevitable miscarriage, the bleeding is heavy and, this is the crucial part, the cervix has opened. An incomplete miscarriage means the fetus has been expelled but some tissue, like the placenta, is still inside. In a complete miscarriage, everything has been expelled, the bleeding stops, and the cervix closes again. And finally, there's a missed miscarriage, where the fetus has passed away but remains in the uterus, often with no symptoms at all.
So, the single most important takeaway here is this. The deciding factor between a potential loss and a certain one is the cervix. If it's closed, the pregnancy might still be saved. If it's open, the process is considered medically irreversible. Okay, this brings us to the question that's probably at the heart of this whole experience for so many people. Why? Why does this happen at all? What's going on biologically?
Well, first, it's so important to understand just how common this is. At least 15% of all known pregnancies end in miscarriage. And the actual number is probably much higher, since many very early losses happen before a person even realizes they're pregnant.
Here's a powerful way to think about this, which comes from the medical source material. It's not about failure, but about a biological protection mechanism. You see, the vast majority of early miscarriages happen because of random chromosomal abnormalities. The body recognizes that the pregnancy isn't developing in a healthy, viable way, and it ends it. In a way, it's a form of biological mercy.
And that leads to a really crucial distinction doctors make. A sporadic miscarriage is a one-time random event. It's tragic, of course, but it says nothing about a person's ability to have a healthy pregnancy in the future. Recurrent miscarriage is different. That's defined as 3 or more losses in a row, and that pattern suggests there might be some underlying issue that's worth investigating.
So, how do doctors figure out exactly what's going on and decide on the best course of action? Let's take a look at the actual diagnosis and medical care involved.
The diagnostic process is very methodical. It starts simply with the patient's history, asking about the bleeding, any pain. Next up is a physical exam to check the uterus and, most importantly, to see if that cervix is open or closed. And finally, an ultrasound gives a direct visual, confirming exactly what's happening inside.
Now, if a miscarriage is diagnosed as inevitable, incomplete, or missed, medical intervention is often needed to help the uterus empty completely and, really importantly, to prevent infection. This is typically done in one of two ways: medically, using drugs to help things along, or surgically.
And the choice of surgical procedure is critically dependent on timing. Before 12 weeks, the fetal tissue is very soft, so a procedure called a dilation and curettage, or DNC, can be done safely. But after 12 weeks, fetal bones have started to form. A DNC then becomes dangerous because those sharp bone fragments could actually perforate the uterus. In those cases, if medical management doesn't work, a different procedure might be necessary.
For one specific cause of recurrent miscarriage, a condition where the cervix is too weak to stay closed, there's a proactive treatment. It's called a cervical cerclage. It's basically a stitch that's placed in the cervix early on to reinforce it and help keep it closed until the baby is ready to be born.
So let's just quickly recap the key takeaways here. First, miscarriage is a precise medical term for a loss before 24 weeks, and that timeline is all defined by fetal viability. Second, and this is so important, the vast majority of these are random biological events and they are not anyone's fault. And finally, the medical response is carefully tailored to the specific type and timing of the loss to ensure the best and safest care. And that brings us to a final thought. Now that we have this clinical knowledge, this clear language, how can that change the conversation we have around pregnancy loss? How can a precise understanding help us replace stigma with support and confusion with compassion? It's something to think about. Thank you for joining this explainer.